ठीक है छोटू. So let's talk about the adrenal gland or suprarenal gland. With adrenal gland, it is two in number because it is over the kidneys and it has got two parts, which are adrenal cortex and medulla. Adrenal gland is controlled by the hormone secreted by your pituitary, that is your ACTH. But as I said that there are two parts in adrenal gland, the adrenal cortex and medulla. You have to remember that the center part, the adrenal medulla, is not controlled by ACTH. ACTH is only controlling adrenal cortex. AC, adrenal cortex. Now, this pituitary for adrenal gland is secreting ACTH under the influence of hormone coming from the hypothalamus, that is CRH. So, how is the road going? CRH, ACTH, and controlling your adrenal cortex. Your adrenal cortex has got three layers from outside to inside: GFR, glomerulosa, fasciculata, reticularis. Glomerulosa will secrete a hormone called as THAS. Fasciculata will secrete a hormone called as cortisol, and reticularis will glomerulosa is going to secrete aldosterone, and your fasciculata cortisol and reticularis, the innermost, is going to secrete DHAS. Okay. The adrenal medulla, it is going to secrete epinephrine and norepinephrine, a little bit of dopa also. Now, in this, we are going to talk about three diseases. Number one would be high cortisol, that is your Cushing syndrome. Number two will be high aldosterone, that is your hyperaldosteronism. And number three will be increase in the epinephrine, norepinephrine, leading to pheochromocytoma. Okay. One thing which also, before I should mention that your ACTH, it basically indirectly stimulates the melanocyte stimulating hormone also. So in any disease, wherever you will see ACTH increasing, subsequently MSH will also increase, melanocyte stimulating hormone. And if melanocyte stimulating hormone will increase, the patient will give you hyperpigmentation. The moment they say hyperpigmentation, मतलब ACTH बढ़ रहा है, MSH बढ़ रहा है क्योंकि, ठीक है. Now, first disease hyperaldosteronism. But a hyperaldosteronism may you are having high aldosterone. Now, aldosterone actually is working in sync with RAS system. Now, what is RAS system? Renin, angiotensin, aldosterone system. So, how does this system works? Whenever there is decrease in the blood pressure, there will be decrease of blood flow to the kidney. The GFR of the kidney will go down. Kidney will be at a risk of going into failure, so or acute injury. So kidney does not want that. So from the GE cells in the macula densa, you would near the efferent arteriole it is. So you would secrete renin. The moment renin is secreted by the kidney, this renin converts angiotensin into angiotensin 1 in the liver. Now, angiotensin 1 in the liver will convert into angiotensin 2 in the lungs. This angiotensin 2 has two functions. Number one, it constricts the blood vessel, leading to increase in blood pressure. And second, activating the zona glomerulosa of adrenal cortex. The moment you activate zona glomerulosa of the adrenal cortex, you secrete more aldosterone. And aldosterone works over our ENaC channel by absorbing the sodium and water. It absorbs and it releases potassium and hydrogen in the urine. So now you are absorbing more sodium, more water, so you are increasing the blood pressure. So this is how the aldosterone is working. It absorbs sodium and chloride plus water. This is what is happening by the aldosterone. And aldosterone is in direct relation with renin. So generally, if you ask me that who controls aldosterone more, that is your renin, RAS system. But aldosterone is an independent hormone which is coming from the zona glomerulosa. So if I'm seeing high aldosterone in the body, there can be two reasons for it. That something has happened to the zona glomerulosa. There is nothing doing with the RAS system. If aldosterone is high, because there is some problem in the zona glomerulosa of the adrenal cortex, I called it as primary hyperaldosteronism. And if my aldosterone is high, because there is high renin, that means this is not the direct problem. This is the indirect problem. It is secondary hyperaldosteronism. So I have two types of hyperaldosteronism, primary and the secondary. Primary, when the problem is directly in the adrenal gland, and secondary, when the problem is with anything leading to decrease in the blood pressure. How do I differentiate? And what are the features my patient will have? देखो, Primary hyperaldosteronism में the most common cause is a problem with the adrenal gland, and the most common problem in that is hyperplasia of the adrenal gland. It can be tumor of the adrenal gland also, Shoto, and that tumor is called as Conn syndrome. बहुत ही famous name है ये Conn syndrome. ठीक है, तुम भी तो कॉनिंग करते रहते हो ना पूरे टाइम. चलो, what will be the features of both of them? Hypertension तो होगा ही because you're increasing the BP. Potassium hydrogen you are losing, so hypokalemia and metabolic alkalosis. Plus, in primary hyperaldosteronism, you will not find edema, but in secondary you will find edema. Why? Because BP is maintained by either kidney, liver, or the kidney, heart. If there is any problem in these three organs, patient will start having edema. पढ़ा ही आपने. So how do I differentiate? On the basis of features मेरे को नहीं मिलेगा differentiation. Then what? I check the renin levels. Renin levels in primary कोई लेना देना ही नहीं है. So renin is low. Renin levels in secondary, yes, it will be high. So I check the aldosterone to renin ratio. Aldosterone to whether it is primary or secondary, aldosterone to high. Renin in primary is low, so the overall ratio becomes high. Whereas renin in secondary is also high. So the ratio is low in comparison to primary. This is one test which you can do by differentiating between primary and secondary. But the investigation of choice for primary one is salt infusion or saline infusion. Normally, if I give you saline or if I give you salt, you don't want to take that or keep that salt or saline inside your body. You don't want to keep that. You want to release it because more salt will increase the blood pressure. So if you want to release the sodium, if you want to release the salt or the water, you do not want your aldosterone to work. But in these patients who are having primary hyperaldosteronism, even after giving saline and salt, you will find that aldosterone is working more. So this is primary hyperaldosteronism कि भाई aldosterone को कोई मतलब ही नहीं है कि बॉडी को क्या चाहिए क्या नहीं चाहिए उसको तो ज्यादा काम करना है. ठीक है. For secondary, check the underlying cause, which disease it is, and treat the cause. For treatment of primary hyperaldosteronism, give the aldosterone receptor blockers. And if it's a tumor which is causing it, remove it. But the thing is that because the patient is hypertensive, you cannot take this patient directly on the OT table. You first have to regulate the blood pressure. Hemodynamic stability is the most important part. Until unless it's not an emergency surgery, it's not an emergency surgery. So first you give spironolactone, you make the blood pressure of the patient normal, and then you take the patient on surgery. Okay. Then you have Liddle syndrome. Liddle syndrome, it is due to hyperactivation of the ENaC channel, leading to ENaC channel. But ENaC channel is the place where the aldosterone works actually. So hyperactivation of the ENaC channel due to a mutation leading to overactivation. So what will happen on an ENaC channel? You will absorb more sodium, more water inside the body, and you will release more potassium, more hydrogen. So patient will have hypertension, patient will have hypokalemia, patient will have metabolic alkalosis. So same features as primary or secondary hyperaldosteronism, but because your ENaC channel is hyperactivated, it gives negative feedback to renin. If renin is low, angiotensin is low, aldosterone is low. So you have same features of hyperaldosteronism in a disease which is actually showing you hypoaldosteronism. समझे आप? This disease is called as Liddle syndrome. What is the treatment? Block the channel. Give ENaC blockers. Amiloride. To differentiate between primary, secondary, and Liddle syndrome, देखो छोटू, in primary, everything is low except your aldosterone. Renin low, angiotensin low, but aldosterone is very high and the overall ratio will be high, aldosterone to renin ratio. In secondary, everything is high. Renin is high, angiotensin is high, aldosterone is high. So overall ratio is less in comparison to primary. In Liddle, everything is low except the ratio, which is normal in comparison to what are the symptoms you are getting. So everything is low in Liddle. सब कम है क्योंकि ओवर एक्टिवेशन इनएक चैनल का हो रहा है एंड दिस रेशियो इज नॉर्मल. So any of these patients, you see how different they are, but any of these patients will give you same symptoms: hypertension, hypokalemia, metabolic alkalosis. Okay. Now, this is a disease, adrenal insufficiency, which can be primary, secondary, tertiary, where the adrenal cortex is not working. So it can be primary where there is any destruction of the adrenal cortex directly. In India, it is due to TB. Worldwide, it is autoimmune destruction. So you will find that all the hormones coming from the adrenal cortex will be low. Patient will have low DHAS, low cortisol, low aldosterone. But because it's primary, the problem is only in the adrenal gland. Pituitary and hypothalamus, they will be secreting more. So one arrow down, both two up, primary. Okay. What is the problem in these patients? In these patients, beta BP is going low, blood sugar is going low. Just So you need to maintain the hemodynamic stability in these patients. ठीक है? Homeostasis बना के रखना है इन patients के अंदर. So you give steroids. So what is the treatment? Whether it is, the treatment is hydrocortisone and fluorocortisone. स्टेरॉइड देने पड़ेंगे भाई मैनेज करने के लिए. एंड व्हाट इज द टेस्ट बाय विच यू अंडरस्टैंड कि नहीं यार ये प्राइमरी प्रॉब्लम इज ओनली इन द एड्रेनल ग्लैंड, यहां से नहीं आ रही है ये. You give ACTH stimulation test because you know that all these hormones are in control of ACTH. तो आपको लगता है कि यार patient is not having these hormones, probably maybe the problem is in ACTH. Pituitary secrete ही नहीं कर रहा है. So you give the ACTH from outside. It is called as co-syntropin test. ACTH stimulation or co-syntropin test. Even after giving ACTH, this will not be secreted. And then you will understand कि भाई adrenal gland काम ही नहीं कर रहा. There's some problem with the adrenal gland cortex. It can be secondary or tertiary also. Secondary means problem with the pituitary. So in those patients, ACTH will be low, and that is why these hormones are low. Or tertiary hypo, adrenal insufficiency would be CRH low, ACTH low, and all these three low. Whether it is secondary or tertiary, symptoms तो same ही आने हैं. Treatment फिर से steroid देना पड़ेगा. What is that? Dexamethasone. See. Okay. Pheochromocytoma, very important for your test and for your main exam rather, because there were questions coming from this. Pheochromocytoma, we know that there are neural crest cells which are called as chromaffin cells. They produce a part in the adrenal gland which is secreting the norepinephrine and epinephrine. And they also give rise to sympathetic ganglia which secrete norepinephrine, epinephrine. So whenever there is increased secretion of norepinephrine or epinephrine, we call it as pheochromocytoma. But if this norepinephrine or epinephrine is coming directly from the adrenal gland, we call it as pheochromocytoma. But if it is coming from the sympathetic ganglia, not the adrenal gland, then we call it as paraganglioma or extraadrenal pheochromocytoma. The most common site for extraadrenal pheochromocytoma is the ganglions at the junction of superior mesenteric and inferior mesenteric vein. We call it as organ of Zucker-Candy. These pheochromocytomas, because they are arising from the chromaffin cell organ or chromaffin cell sympathetic ganglions, so there it is also called as chromaffinoma, and it has rule of 10 that 10% are bilateral, 10% are extraadrenal, and 10% are malignant. How do you get the symptoms in these patients? Obviously, when the epinephrine and norepinephrine will increase, it will increase the sympathetic activity. Patient will present with HSP, headache, sweating, and palpitation. Most common symptoms, severe headache. These norepinephrine and epinephrine, they work at the alpha and beta receptors. So obviously, vasoconstriction, increase in BP, and increase in the heart rate will be seen. How do you investigate? By fractionated metanephrine levels. This is the investigation of choice you see in urine. याद रखना बेटा ये word metanephrine. Okay. And MRI can also be done to localize the tumor and getting the size of the tumor. And treatment के लिए first you give alpha receptor blocker, then you give beta receptor blocker, and then you do surgery. This was a question in the main exam. So हमेशा alpha receptor करना है, ठीक है? And then beta, and then surgery. This is your pheochromocytome. And then you have your Cushing syndrome. Cushing syndrome, increase in the cortisol. Cortisol is secreted by zona fasciculata. Normally, cortisol is there to manage our blood sugar levels. And because our blood sugar levels keep fluctuating throughout the day, so whenever we go into hypo, cortisol level goes high. Whenever we are already having glucose, cortisol is less. So as our sugar fluctuates throughout the day, cortisol also fluctuates throughout the day. But in Cushing syndrome, there's high cortisol. So you will find that this diurnal variation, the variation which is happening in the cortisol level normally in 24 hours, that's lost. So normally it is, having these variations like this. But right now, one thing is cortisol is high. So it is high and it has not having any variation. So Cushing syndrome may दिखता है. What is the reason of this? The reason could be iatrogenic, that the patient is taking steroids from outside, which is working as they're a steroid. So it is increasing the cortisol in the body. Or there is some problem elsewhere which leads to high cortisol release from the adrenal gland. Now, who is controlling your adrenal gland? The hormone is ACTH. Who can secrete ACTH? Pituitary. So one problem is that there's a problem in the pituitary because it is secreting more ACTH. That is why the cortisol is being released from here. Or there are some tumors like lung tumors, thyroid tumors. They are actually not related directly to ACTH, but they make release of ACTH more. And if the ACTH is secreted more, it can lead to more cortisol release. So it can be iatrogenic, self-implicated, or maybe extra-adrenal. Now, what will happen? In the iatrogenic, it's just that you're taking a steroid from outside. You're not stimulating anything related to ACTH. So Cortisol will be high, but ACTH will be low in iatrogenic. Whereas in extraadrenal pathology, what will happen? That cortisol high because of ACTH high. So this is how you differentiate. If ACTH is high, it stimulates MSH. And if it stimulates MSH, pigmentation will be seen. So in primary or iatrogenic, you're not having any pigmentation. Whereas in extraadrenal, because it is ACTH dependent, you will see pigmentation. Okay. Now you have lemon on stick appearance. This lemon on stick appearance, patient gets too fat and the peripheries will be very, very, very thin. A moon-like face. What do you do if you suspect Cushing's? Check the 24-hour urinary cortisol. It will be high. Then you give low dose DEXA. With low dose DEXA, you can convert all the cortisol which is there in the blood. You can reduce it. So if you give low dose DEXA and your cortisol reduces, that means it was iatrogenic because it is not related to pituitary. It is not related to ACTH basically. So low dose DEXA cannot control the ACTH release, neither by the tumors nor by the pituitary. So if you give low dose DEXA and your cortisol decreases, that means it is iatrogenic. But if you give low dose DEXA and your cortisol is still high, that means it is ACTH dependent. Now, for to find ACTH dependent, that whether ACTH is coming from pituitary or ACTH is coming from some tumors, you need to give high dose DEXA. The dose is 8 milligrams. This 8 milligram high dose DEXA suppresses the pituitary ACTH release. So if you give high dose DEXA, your ACTH decreases. That means the ACTH was coming from pituitary, and the reason for high cortisol in the body was pituitary tumor. Whereas if you give high dose DEXA and your ACTH is not reduced, that means this ACTH is not coming from the pituitary because pituitary ko to high dose DEXA will suppress. So pituitary is suppressed, but still ACTH is coming. That means this ACTH is coming from some other side, and therefore the reason of Cushing syndrome is ectopic release of ACTH, like in lungs tumors and thyroid tumors. Okay. Whenever pituitary is the cause of Cushing syndrome, I call it as Cushing disease. So if they're writing Cushing disease in a patient, that means they're already telling you that the patient is having pituitary adenoma. The cause of the Cushing syndrome is pituitary. What do? You give drugs to decrease the cortisol, like ketoconazole, meterapone, and etomidate. You give cortisol receptor blockers like mifepristone, and you will give the drug to reduce the ACTH secretion by giving somatostatins. Okay, so this is all about the discussion about the adrenal gland. I'll see you in the next video, Shodo. Diabetes.